It is my honor to introduce you our expert speaker, Dr. Lindsay du Plessis. Dr. du Plessis holds a BA in sociology from UC Berkeley, an MPH from Emory University. She earned her Doctor of Public Health in Community Health Services from UCLA. She has an extensive public health background, addressing health disparities and collaborating with community partners and implementing interventions as well as prevention strategies that empower and improve outcomes among marginalized community. In her current role as the community engagement lead at CMQCC, she organizes and implements outreach activities in partnership with local, regional, state of California, and national agencies to reduce maternal and infant morbidity and mortality. She is a breast cancer survivor who has triumphed over adversity, bringing a unique perspective to her work in community and maternal health. Her personal experiences have fueled her passion for advocating for health and well being, especially in undeserved communities. So, without further ado, Dr. Lindsay du Plessis.
All right. Thank you so much. Thank you for that warm welcome. Good afternoon, everybody. I know you're all full, so I hope you're ready for this conversation. Happy Friday. Thank you so much for having me. It is really an honor to be here and to kick off Black Maternal Health Week and to really talk about the work that I've been doing at CMQCC for the past 2 years. So my name is Lindsay du Plessis, and I am the Community Engagement Lead at CMQCC, and I am leading the low-dose aspirin campaign to reduce preeclampsia and related preterm birth. Okay, so at CMQCC, we try really hard to use inclusive language, acknowledging that all people who have babies do not identify as mothers. And so you'll hear me say birthing people, maternal, they, them, she, her. And I really like to mix it up so that I can honor everyone who is having this amazing experience. And then family can be broadly defined, right? And it can encompass partners, husbands, wives, support persons, loved ones, community. It's really any persons, or groups that the pregnant or postpartum patient really get their support from. So I have no financial disclosures or conflicts of interest with the presented material here, and this is just to serve as an educational resource. So I'm sure most of you know about CMQCC. It stands for the California Maternal Quality Care Collaborative. And the mission of CMQCC is to end preventable morbidity, mortality, and racial disparities in California maternity care. And we've been around for a while. We are celebrating 17 years. And we at CMQCC are really committed to evidence-based and data-driven quality improvement. CMQCC has a formula that combines outreach, stakeholder wisdom with research and data into quality improvement toolkits to address pressing threats to maternal health. And so some objectives for today. We're going to review some risk factors, identifying those who meet the low-dose aspirin criteria for preeclampsia prevention, discuss best practices for respectful, compassionate discussions with patients, including some scripts and some tools for really tackling these difficult conversations and addressing structural racism as a mediator of health outcomes. We'll talk about some tips for essential patient education, and then we'll discuss the LDA campaign and the importance of community-based QI implementation. So Dr. Boyd earlier talked about these amazing women. So what are a few things that Serena Williams, Tori Bowie, and Alan Felix have in common? As we can see here, they are all women of color. They are all Black women. They all have a lot of resources. They are all Olympic athletes. And that being said, they are very aware of their body and its function. They know when something is right, and when they're feeling 100%. And they also know when something's not right. And so they've all experienced traumatic births. Serena Williams has shared her near fatal birthing story with her first daughter. After giving birth, she told a nurse, something's not right. I need a CT scan and a blood thinner. And the nurse actually suggested to her that the pain medication was probably leaving her kind of loopy and confused. And so when the ultrasound revealed nothing, they did this CT scan, which proved that she had a pulmonary embolism and showed that several small blood clots had traveled to her lungs. Now, our hearts go out to the family of Tori Bowie, who lost her life last year due to pregnancy complications. And as Dr. Boyd mentioned, she was 8 months pregnant and in labor alone at the time of her death, according to an autopsy that was reported by the New York Times. And this autopsy listed respiratory distress and eclampsia as possible complication. And then there's Allison Felix, who never imagined that she, would experience a serious problem during her pregnancy. She ran every day. She was very active, very healthy. Yet with 2 months to go until her due date, she was diagnosed with severe preeclampsia. She had to be rushed to the hospital, have an emergency C-section, and her baby was in the NICU for about a month. So all of these women have access to quality care. And so it goes to show that no matter your education, no matter your income, Black women are 3 to 4 times more likely to die from pregnancy-related causes. And eclampsia occurs after preeclampsia. So this is really where community can bridge that gap. And so on this slide, you see at the top, it says, racism alone is not killing Black mothers. Inaction is. And so we really need to wake up and get to action because it is time and it has been time. So just a brief kind of definition of preeclampsia. It's new hypertension in pregnancy with direct effects on both the mother and the fetus, and often has protein in the urine and may lead to seizures and severe injuries to the kidneys, liver, heart, and brain. The fetus is sometimes delivered preterm with possible long-term complications, undersized and admitted to the NICU, and in severe cases, stillborn. So a bit of level setting, specifically about California, about how patients are dying in this perinatal period. So for the pink one that you see here on the slide, this is hypertensive disorders of pregnancy. So that includes severe chronic hypertension, preeclampsia with severe features, it might be eclampsia, anything that's on that hypertensive spectrum. And so we've made a lot of changes, right? We've made some progress in this area, partially because of the collaborative work being done across the state of California with the help of CMQCC reviewing data, working in teams, and exchanging best practices. But it is still a major cause of maternal death in all of these groups that you see here, but particularly for Black birthing people. And so this slide makes myself and my colleague, Dr. Williams, and I sick to our stomach because the scale that you see here for Black birthing people is 1 to 3, right? So the size of this bar is misleading, but they had to fit it on the page so that people that look like me, people that look like Dr. Williams, the death is so much that it doesn't even fit on one page. It doesn't even fit on the slide. So that's deep, right? That's a big deal. And so you see here for Black birthing people, 5.6 compared to everyone else, like 1.2 is a lot. That's a big difference. So we really need to take this seriously. So why low-dose aspirin? Why has the March of Dimes, why has CMQCC committed so much time, so much energy, so many resources to promoting aspirin in our communities? And why we are asking you all to help promote low-dose aspirin is because it is the only preventive measure that we know that has good evidence to support it that can prevent preeclampsia. So low-dose aspirin in pregnancy can support healthy placenta development, preventing changes that can lead to high blood pressure. And taking low-dose aspirin, those who are taking low-dose aspirin are more likely to deliver at full term and less likely to have preeclampsia. So let's go over a few facts. So hypertensive disorders of pregnancy complicate about 15% of all pregnancies nationally. And while preeclampsia complicates about 3 to 4% of pregnancies yearly, this causes maternal and newborn morbidity and mortality, right? But this really depends on the populations that you all are serving. So if you're working in a population that serves Black identified or advanced maternal age patients, those are some of the most high-risk patients and groups. And if you're seeing a lot of those patients, you will be seeing a lot of preeclampsia. So prophylactic low-dose aspirin, 81 milligrams, for those who have screened at risk, reduces fetal growth restriction, preeclampsia, preterm birth, and perinatal death. And it's the only intervention for the primary prevention of preeclampsia. So the development of preeclampsia increases the risk of chronic hypertension and cardiovascular disease later on in life for the birthing person as well as for that baby. And so LDA commenced between 12 and 16 weeks and taken daily through delivery for those who meet that criteria is really still in need of wide implementation and a standardized fashion nationwide. And so screening for preeclampsia risk factors, the ability for early intervention, which is so important, as well as prevention and closer monitoring during pregnancy when indicated. And we're not making this up, right? This is confirmed by the United States Preventive Services Task Force, by the American College of OBGYN, and the Society for Maternal Fetal Medicine, right? So all of these big bodies agree. And in 2021, they made a joint recommendation for daily prenatal low-dose aspirin for birthing patients with any high-risk preeclampsia factors or one or more moderate risk factors. And we'll get into those risk factors shortly. So a simple over-the-counter low-dose aspirin, 81 milligrams, can reduce preeclampsia by 15%, preterm birth by 20%, fetal growth restriction by almost 20%, and perinatal mortality by more than 20%. So this really translates to healthier moms and healthier babies, and that's ultimately our goal. So unfortunately, these recommendations have been really slow to become widely used, right? So multiple studies find that less than 25% of eligible women are offered to take low-dose aspirin. And women with chronic hypertension are the highest utilizing group, but among them, only 50% are taking low-dose aspirin. And this one really hits hard. Among Black pregnant people who are eligible, only 10% are receiving LDA, right? So are the providers not prescribing it, or are the patients not taking it? So medical information and prescribing, it's just not enough, right? There's barriers to adoption. And so this is multifactorial, and we heard this earlier. So there could be information overload, right? Or confusion about preeclampsia, right? I never heard about preeclampsia before I started at CMQCC. You know, there could be difficulty obtaining a prescription. You know, your provider can fill that prescription for you, or you can just go to your local, you know, Walgreens or CVS or Target and get it over the counter. And so also there could be difficulty with pill taking, like pregnancy fog, or, you know, some health and other personal challenges. And then there's fear of medication in pregnancy, right? There's lots of tales and there's lots of concerns out there. And could be a reluctance to take a medication while you're pregnant, let alone every single day. There's perception of mixed messages among healthcare providers about the safety of aspirin. And then there's perception of stigma about some of the risk factors like obesity. So, you know, some of these may resonate with you all in your experience, and we know that implementation is hard. And so if there's a workaround that you all know, I would love to talk more to you. So some other reasons why low-dose aspirin has not been widely adopted, you know, it could be something new in a clinic, right? Or, you know, changing office workflow. The screening tool could be really complex and complicated or awkward to use, especially it could be confusing for patients or non-clinical users. You know, providers are not educated about the importance of aspirin. And then this is a big one. difficult discussions with patients around things like race and low SES. These are just difficult discussions to have, but we need to have these discussions, right? And I understand that you might see your provider for about 10, 15 minutes, and this really just gets brushed over because you don't have time to talk about it. And then lastly, we all know lack of trust in the medical system. All right, so let's talk about risk and risk factor screening. So clinicians should bring this up in the first prenatal care appointment with the goal of starting in that 12 to 16 week period. Now, there has been some benefit that has been shown all the way up to starting it up to 28 weeks. So even if someone is late to their prenatal care appointment or getting prenatal care, there's still an opportunity. So risk factor screening for all prenatal care patients, whether they are deemed low risk or high risk. And then we want all prenatal care providers to know about this and be screening their patients because of the risk factors. And because these risk factors, many of them could be demographic and not clinical, right? So let's look at the risk factors for preeclampsia. So I know this is a very, very busy slide, so I'm going to walk you all through it. So let's look at this left side, the high risk factors. So if you have any of these, the patient should definitely be on low dose aspirin. Preeclampsia in a previous pregnancy, chronic hypertension, multifetal pregnancy, twins or triplets, diabetes, kidney disease, or autoimmune disease like lupus. And on the right-hand side, we have our moderate risk factors. And these are the factors that can increase your risk, but not as much as the high risk factors. So if you have more than one, then the recommendation for you to get started on LDA. So like first baby, right? Nulliparity. That's a lot of patients, right? And then here you see obesity defined as a BMI of over 30. That's not that high. And then Black race. Now let's be clear about this risk factor. The risk factor is exposure to systemic racism. People get pretty lazy at times and they just say, oh, Black race as a risk factor. And it is important to note that there is nothing wrong with being Black. I personally love being Black, right? I think it's wonderful. But it also comes with a history that is really full of environmental, social, historical inequities that shape health exposures, access to healthcare, and unequal distribution of resources. Now, this is not about biological propensities. This is about the epigenetics that happen as a result of that history. Same goes for lower income, and there's also personal history factors, like if you had a prior low birth weight baby or some other adverse pregnancy outcome. Also, advanced maternal age, over age 35, right? So I had 3 of these risk factors. I had my child at 41. I'm a Black woman, right? And it was my first baby. And my OBGYN never mentioned the word preeclampsia to me. So as you're looking at this list, I just want you to think about how many of your patients would fit into these categories. And for Black race and lower income, some groups say that you can even consider low dose aspirin if those are the only risk factors that that patient has. And given how safe aspirin is, they will make that recommendation. So when having compassionate discussions with patients about this, our responsibility really is to ensure that our patients feel empowered, we want them to be well-informed, and we want to equip them to make the best decisions for themselves and especially for their baby. And so we need to be able to explain the risk factor screening process benefits, right? Because this can help identify those who are at higher risk for developing preeclampsia. And we can provide an opportunity for prevention. And lastly, it's important to start these discussions early on in pregnancy because it might take an appointment or 2 for people to really get the information that they need to be able to digest all that information and to get their questions answered. So let's talk about exposure to systemic racism as a risk factor. When you're talking about exposure to systemic racism as a risk factor. This is not a comfortable conversation to have, but as I mentioned earlier, it is needed and it is necessary. And it is important to say the word racism and to help patients really understand that this is nothing that they did. And there's nothing genetically wrong with you or some genetic predisposition. It is about environmental, social, and historical inequities. And so structural racism is recognized as a mediator of health outcomes and has impacted preeclampsia rates. This risk factor has been well established and studied, acknowledging that discussing this factually and respectfully is best practice. And so for non-Hispanic Black women who are disproportionately affected by preeclampsia, we really need to be talking about these risk factors. And then lastly, it's believed to be due to toxic stress from a history of racism and discrimination in American healthcare and throughout history. So we're talking decades of constant stress on the body, which we know worsens overall health outcomes. This is heightened during pregnancy, and we've all heard of the concept of weathering, right? This is constant wear and tear on the Black woman or the Black birthing person's body. It's generational trauma, and then lived experience actually becomes biology. So this is a famous quote by Professor Mahmoud Fathallah, who was an OBGYN. It says, "Women are not dying because of diseases we cannot treat. They are dying because societies have yet to decide their lives are worth saving." Now, I personally believe that they are worth saving, and that's why I do the work that I do. So the March of Dimes and the Preeclampsia Foundation have looked at different factors to consider during your education with patients. And they have found that less than half of pregnant patients know the signs and symptoms of preeclampsia. Like I said, I have a lot of resources and I knew nothing about this. Ask about specific signs and symptoms rather than asking if there are any signs and symptoms that your patient would like to report. We just need to make sure that these patients, their families, their communities know these signs and symptoms of preeclampsia, because these are the people that they're connected to. And so knowledge is power. We have to empower our patients, right? Patients have historically reported a lack of understanding about preeclampsia. Knowing preeclampsia signs and symptoms is the first line of defense for early diagnosis and treatment. The disease can progress pretty rapidly, and patients understanding the signs and symptoms that require immediate reporting can really save lives. Patients and their family, friends, community often are the first responders. So we know that education is power, and it's so vital. Understanding how severe preeclampsia can be may improve reporting and treatment compliance. And then lastly, patient education improves clinical outcomes. So, in terms of knowledge level, in terms of written patient education, we want to make sure we're educating at a 4th to 6th grade level, right? We want to be as clear as possible. Someone may have a PhD, but someone may not have a PhD in preeclampsia. So we want to simplify as much as we can. And, all of us need simplification sometimes, right? Especially when it is not our area of expertise. And so for verbal patient education, we want to educate at the patient's knowledge level. And we really want to assure the patients that, that they understand what's being told, right? What we are educating them about. And we want them to be able to repeat it back. And we want to give time so that they can ask questions. And if providing instructions, it's really best to have that patient and or family member demonstrate it back. And then lastly, provide some sustainable resources, right? From the Preeclampsia Foundation and even from CMQCC toolkits, right? And you can find those at cmqcc.org. All right, so now I'd like to play a short video from the Hear Her campaign.
I was so married to my birth plan. I imagined what it would be like, and I studied and I read and I went to classes, and I felt really prepared to have this natural birth. But what I did not prepare for was a scenario where everything goes south. Hi, I'm Allison Felix. I'm an Olympic athlete and a mom, and this is my story. Being my first pregnancy, I was feeling really great. I trained throughout my pregnancy. I was running every day. I was in the pool. I was lifting weights. I felt really strong. So it was my scheduled routine appointment. I was sitting back in one of the rooms waiting for the doctor to come in to see me. And when she did, she mentioned that she wanted to hook me up to be monitored. I started to think, I wonder if this is normal, and I wonder what's going on. And finally she came back and she said that she had some concerns and she wanted to send me to the hospital for further testing. That's when my heart kind of sank and I was like, wow, this must be something, I kind of heard of the statistics of Black women being more at risk for complications, but being a professional athlete, I never imagined myself in this situation. At 32 weeks, I was diagnosed with severe preeclampsia. My husband was coming from work and he met me there and we were sitting together and the doctor came in and she just said that things were still concerning and that they wanted to admit me to the hospital. That's really the point where things got scary. Doctors and nurses were coming in and they were concerned, and I remember at one point the doctor rushing in and saying that, we cannot wait any longer. We're gonna have to rush you in for an emergency C-section. I am scared, I'm terrified, but I'm not really concerned about myself. I'm just worried about this little tiny baby who is not ready to enter this world yet. All I was thinking is just, I want a healthy baby. I didn't imagine, not even being able to be in the same room as my daughter and not being able to hold her until even the next day. And Cameron was in the NICU for a month after she was born. I stayed in the hospital for a while and I had some complications that come along with preeclampsia. It was just a really scary, tough situation. But I feel so blessed that I came out on the other side of it. There are so many women who do not walk out of the hospital. They are not there to raise their children. I really want women just to be aware, to know if they're at risk, to have a plan in place, to not be intimidated in doctors' offices, and to be heard, to be persistent about anything that does not feel normal, because I know how important it is. I know how scared I was, and I know how I didn't feel prepared or educated, and I don't want anyone else to feel that way. Hear her.
And education, right? So important. And like we've been mentioning, she had so many resources, right? And she still had this pregnancy. Actually not a difficult, it could have been worse. Her outcome could have been worse. So, all right. So here we have a driver diagram that my colleagues and I put together for this LDA project. And essentially a driver diagram is a visual display of what drives or contributes to the achievement of a project aim, right? So you see here, 80% of at-risk patients will utilize daily low-dose aspirin during pregnancy to at least 36 weeks of gestation. And in order to achieve this aim, we have these primary drivers. So we need to change provider practice. We need to engage patients, uplift patients in their voices and their stories, engage community partners, and then create a data collection system. So I know this is a lot. I understand, I know it's a very, very busy slide, but it's not meant to be overwhelming. I really just wanted to show the extensive amount of work that we've been doing, and the different layers that are needed for implementation. And so LDA for prevention of preeclampsia is proven science. But how do we improve use and adherence? Through implementation tools and collaborative learning. And so as we can see here, this is a deeper dive into our driver diagram, which we have used to organize implementation. So here, there's our primary drivers we just saw on the previous slide, and then we have our secondary drivers with proposed ideas to help drive change, and how CMQCC really wants to create a learning and sharing collaborative. All right, so community-based QI implementation and roles of influencers. So healthcare providers, social media, family members, church, Black infant health, other CBOs play a crucial role in ensuring adherence to LDA. Providers can educate patients about the importance of taking low-dose aspirin as prescribed, monitor their progress, and address any concerns. So everyone that you see here can provide ongoing support to promote adherence throughout the pregnancy. And additionally, pharmacists can also play a crucial role in counseling patients on proper use. All right, so I'm a public health person and a community person. And so I like conceptual models. So I put this together. It's a community-centered approach to promote LDA adherence and using a methodological approach to center and engage community. And I want to be clear that this does not include all populations and interventions within the scope of this project. This is just the approach that we are taking for this LDA initiative. So you can see here the population. We must include and educate providers, communities, pharmacists, nurses, doulas, midwives, and other birth workers. And then we have our interventions that I'll get into shortly, like education, outreach, and then data. And this will help us establish guidelines for a community-centered promotion for LDA. And then eventually it will allow us to scale up. So I'd like for you all to think like, what populations am I missing here, and thoughts on different interventions and anything else that we could be doing or should be doing. In our scaling up phase, who are some partners and what are some strategies that we can consider? So communities really are the next frontier and so important. And so I'd like you to please look at this word cloud and see how your organization can show up or have an active role in advancing maternal health. You may have some strategies that you'd like to share. So we at CMQCC, yes, we have a hospital clinic kind of focus, right? And now we are incorporating community. And we have finally landed on the right project to include community-based organizations, clinics, community, and patient voices. We know that we have to bridge this gap between hospital, clinics, and communities. We all have to work together. We should have been working together. So uplifting community and patient voices and their birthing stories are so important. Community-based organizations, communities with lived experience can further inform the importance of QI work. Communities and CBOs are so important to bring to the table when doing these types of interventions. So this is just a picture just showing that we're actually getting out there into the community. We're attending fairs, we're going to church fairs and things like that. So we really want to engage community when we're doing this work. So the Let's Do Aspirin campaign. So this project has been generously funded by the March of Dimes. So thank you so much to the March of Dimes. So the goal of this LDA campaign is to reduce maternal and infant harms by from preeclampsia by identifying birthing people at risk of preeclampsia early in gestation and encouraging the use of daily low-dose aspirin for the duration of the pregnancy. And so, as I mentioned before, we are engaging in California, throughout California. We are engaging with pilot hospitals that we selected for our first cohort. We are engaging with their clinics, community clinics, CBOs, which are so important, and then patients with lived experience. And so these are the pilot hospital sites that we worked with for our first cohort. 4 of them are down in Southern California and 1 in Northern California. So we have Loma Linda University Children's Hospital, and we're working with 3 of their clinics. Riverside University Health System Medical Center, they have 7 clinics. UC San Diego with 3 clinics. Scripps Chula Vista, which is also in the San Diego area. And then Mercy San Juan up here in Sacramento. And then we're also partnering with Kaiser Permanente, Northern California. So the key elements of this campaign is to really make it easier for providers to screen and prescribe low-dose aspirin, to increase patient awareness of the benefits and lack of risk of low-dose aspirin, and to really increase community awareness of the benefits of low-dose aspirin to support women, birthing people in their LDA decisions. because we know that, yes, these women and these birthing people are delivering, they're having their babies in the hospital, but where do they spend most of their time? In their communities, right? In their clinics. And educational outreach on the benefits of low-dose aspirin. So a bit more about LDA implementation, what we're doing in terms of hospital and clinic outreach. So we have patient and provider surveys, and these are used to identify the barriers and facilitators to aspirin uptake, right? It could be patient education or access or prescribing practices. And we have our surveys in English and in Spanish, and here we have our patient flyer. With a QR code. You know, everybody has a phone, right? So you scan that QR code, it takes about 10 minutes to complete that survey, and you're given an incentive. QI collaborative meetings. So what we do here is we come together once a month. We have hospital site leads on the call, we have clinic champions on the call, we have community-based organizations, and patients from a patient advisory committee that I helped put together, and I'll talk about that shortly. So this is really, really important work, right? Because we can come together and we can collaborate and we can talk and we can listen. And we actually, I've given a platform to patients to share their stories on these calls. And then lastly, data regarding LDA is gathered in the hospital during the med reconciliation process. And there's no extra work to get this information into the MDC. And some of the questions are, was the patient on LDA? If so, what was the dosage? When did they start taking LDA? And when did they stop? And where did they receive their prenatal care? All right, so in terms of patient and community outreach, so you can see here that we have our patient education materials, and they are in English and in Spanish, and we will do more languages as we are able to scale up. So we continue to identify and fine-tune community messaging and outreach materials to educate women about the role of low-dose aspirin during pregnancy. And here we have our poster and our information sheet. And the patient education materials also feature a QR code that takes the patients to the March of Dimes website that provides more information about low-dose aspirin and preeclampsia. And so we encourage patients, as you see here, we encourage them to talk to their healthcare providers about aspirin, as well as highlighting the importance of keeping your baby safe, which is a priority for women and birthing people. And then we also have videos. We wanted to produce some educational videos showing the different provider-patient interaction scenarios, including discussions on maternal health disparities and how to best model those conversations. And so one of the videos we did at one of our pilot hospitals, what's really cool is that, this video has been used for educational purposes in grand rounds in the clinic and hospital settings. And so the patients, this patient advisory committee, which is near and dear to me, this is made up of patients with lived experience who either have preeclampsia or some other adverse health outcome. And they lived around the pilot hospitals that we worked with. And so we meet once a month, and it's truly a sisterhood and a safe space for these folks. And so they have met with the pilot hospital leads, which I talked about, those QI collaborative calls, to truly enhance the importance of patient and community voices. And we have 11 patients that serve on this committee, and they all have my cell phone number, and we talk offline all the time, and it's really noteworthy that they had their eyes and input on the patient education materials, because we really wanted something that resonated with the patients. We also have press releases where each of the hospital announced what they were doing and announced the LDA campaign. And then, as I mentioned before, just getting out there into the community at different fairs and different events. So this is another example of patient education materials with the prior information in a patient-centered format that we have been providing to our pilot hospital systems on behalf of the March of Dimes, along with the information sheet and the poster that you just saw. And so we created this one specific to the campaign, which the folks on the patient advisory committee weighed in on as well. And so the original preeclampsia risk screening tool was created in collaboration with the USPSTF, ACOG, and SMFM. And so the tool released by the task force can be a bit confusing, as I mentioned earlier, which is why I really wanted to work with the patients on the patient advisory committee to create the should I do aspirin questions, which are written by and for patients. And you can find all of this information, all of our education materials on our website at cmqcc.org, along with patient stories. All right, so my former clinical lead and myself, we went out here. We wanted to be out there in the community, and we wanted to visit these clinics. And so these are just some photos when we did that a couple months back. And also, what's really, really cool is in the middle picture, you can see our poster, right? And it's right next to where the patients are getting their blood pressure checked, right? How easy is that? You get your blood pressure checked, you have your phone. Like I said, everybody has a phone. So you scan that QR code and you get more information, right? And then the other picture, one of our hospital sites actually has our poster in an elevator, right? So it's not just to educate patients and these birthing people, but a grandfather could see this in the elevator, right? An uncle, a cousin or something. So we really just want to make sure that we are educating everybody and we can get these conversations started. So for cohort 2, I just talked to you about cohort 1, what we did with that group. So we will send out invitation letters to invite select hospitals to participate in the expanded LDA pilot in the next couple of months. Recruit a risk stratified by preeclampsia and preterm birth rates, high volume delivery sample of hospitals and their affiliated clinics in California. Continue to shape clinic to clinic QI planning and implementation, and then continue to have these monthly QI collaborative meetings. Patient and provider education tools, be able to provide that to community and patients. Continue to engage with community, and we're going to actually put together another patient advisory committee with women and birthing people with lived experience that are around those pilot hospitals in our second cohort. So we have done some webinars, right? And we want to scale up, and we want to scale up throughout California. And so we had a community webinar last year, and we decided to launch the low dose aspirin webinar series in December of last year. So the first of 5 webinars was titled Discussing Risk Respectfully, which I went over in the first part of my discussion. The second was titled Preventing Preterm Birth and Preeclampsia, How Can Pharmacists Help? And then we'll actually be having a third webinar in the next couple of months to really focus on the importance of doulas. And then we'll have another one on another clinic one, a patient one, and then another community webinar. So the webinars are open to anyone interested in this campaign, and it's promoted on the CMQCC website, all of our social media pages, and invitations will be sent to those who are registered MDC users. All right, so I had to throw this slide in because this just shows that we are really making progress. This is a big win for us. So this sign was placed in a large healthcare provider office, which specifically called out aspirin as a product that may cause birth defects. Now, if I walk somewhere and I'm pregnant and I see this, there's no way I'm going to want to take aspirin, right? And so I had many conversations with this team, and this team at this office consulted with their national quality, pharmacy, and legal department, and they'll be working with the national facilities to update the signage and replace aspirin with a different medication. Okay? Thank you. Thank you. So huge win for us. All right, so I love my patient advisory committee, and I just really, I asked them, like, I wanted them to express why they wanted to join this patient advisory committee. So I'm not going to read all of these. I'm going to pick a couple to just read out loud. One said, I want to help spread awareness to moms with risk factors of preeclampsia so they get the greatest prenatal care, deliver safely, and make it home. It should not be a death sentence for mom or baby. To share my experience and empower women of color with information to advocate for themselves and their babies, I joined the committee to be a living testament about the severity of uncontrolled preeclampsia. And then one more, to encourage, inspire, and educate the African-American birthing community. I am not a medical professional, but I am a living testament to a broken system. All right, so quickly, I'm just going to go over some tools in our maternal data center. And so there are 5 new measures on preeclampsia, and preterm birth that were built into the Maternal Data Center to support hospitals' work in this LDA initiative. So the 5 measures are LDA usage among those at risk of preeclampsia, preeclampsia among those at risk for preeclampsia, preeclampsia rate, preterm birth among those at risk for preeclampsia, and then preterm preeclampsia rate. So once hospitals uploaded their monthly patient discharge data, all of these measures will be auto-calculated into the Maternal Data Center, excuse me. And so using this information available in the hospital EHR system, hospital staff can actually confirm if the patients, if they were at risk for preeclampsia and if they were prescribed aspirin. And if so, how long they took it during the course of their pregnancy. Also, all of these measures are able to be broken down by race and ethnicity, by payer group, delivery method, gestational age, and prenatal care group. So defining prenatal care groups this was a new implementation into the Maternal Data Center to support the collaboration between the hospital sites and their outpatient clinics. And as appropriate LDA use begins in that prenatal care setting, it was really important for hospitals to be able to identify which outpatient clinics their patients were coming from. So from hospital to home, really, really important, right? Because there is a such thing as postpartum preeclampsia, which often is not often talked about. So we need to think and we need to talk about postpartum follow-up. This is a really important slide. So this bar chart is looking at pregnancy-related deaths by cause and timing to death in California. So looking at this left side here, these are the most common causes of perinatal death. You can see here we have cardiovascular disease, hemorrhage, sepsis or infection, hypertensive disorders of pregnancy, thrombotic pulmonary embolism, and amniotic fluid embolism. So looking at the hypertensive disorders of pregnancy line, you can see it's one of the top causes of maternal deaths. Only 8% happens during pregnancy, but the vast majority is happening in the first month or 2 after pregnancy. So it's really essential that we think and talk about the importance of postpartum follow-up. So when we're thinking about hospital discharge and follow-up, we really want to make sure that the patients are getting blood pressure checks. So some hospitals are actually giving blood pressure cuffs at the time of hospital discharge to patients who have some of these hypertensive spectrum conditions to make sure that they are not getting worse when they go home. There are also walk-in blood pressure locations at clinics, local pharmacies, and some of the cuffs are actually Bluetooth enabled so that patients can be monitored remotely or nurses can do outreach calls. So understanding signs and symptoms, so important. And this is really hard because many postpartum patients have these symptoms, but if these symptoms persist and the patient is not feeling well, we have to take this seriously. So if someone has preeclampsia, they are supposed to be seen for follow-up within 72 hours. And this follow-up can be remote. We can use remote patient monitoring or we can leverage technology. And then lastly, transition to the PCP. This is so important. Medication may have changed or just something. We just have to make sure that we're making this transition. So speaking of getting back to PCPs, I just want to make sure that patients are keeping up with their Medi-Cal, right? So I have a colleague that is an expert in this, and so she put this together. Joanne, thank you. She put this beautiful slide together with our comms person, Errol Noel. Thank you so much. And so during that public health emergency, during COVID, Medi-Cal members were able to get their coverage regardless of any changes in circumstances, right? But the annual Medi-Cal renewal redetermination process has resumed and many members are not being covered. So just want to make sure that they are having this coverage. So closing statements. The work continues. We should all be engaging with communities, and collaboration with hospitals and clinics is key. All of us together. We want to provide support to community organizations to be able to do this. Through clinic to clinic and community to community networks, we can help inform the state and nationwide scale up of this project. There is a disconnect with hospital setting and clinics. Community organizations matter, and patient voices are important. And there's an opportunity for interconnectedness of the teams because these kinds of interventions need to engage community. I can't stress it enough, which can enhance and collaborate partnerships and help prevent preeclampsia and preterm births, especially among birthing people of color. We also have some FAQ sheets that, my former clinical lead put together. They're amazing. They're for pharmacists, they're for patients, for communities, so on and so forth. And so we also want to develop an effective piloted low-dose aspirin implementation guide for scale-up for community and hospital providers, community advocates, and with an efficient data collection option. And then a few other next steps. We want to continue to grow our social media campaign because everybody has a social media account somewhere. We want to continue to center patients with their experiences with LDA during pregnancy, participate in community events, engage with the community, track and analyze data, and create NICU family low-dose aspirin patient education materials. So what you can do, learn more yourself and listen. And it's not okay to just check off saying I did my implicit bias training, right? We have to acknowledge our biases and we need to check our biases. We need to educate patients, family, friends about low-dose aspirin and about preeclampsia symptoms. And some key messages to share when patients ask about low-dose aspirin. Low-dose aspirin is very safe to take. It's safe. It's safely used in all races and ages. LDA can make pregnancies last longer and keep moms and babies safe. And then if taking LDA, it is important to take it daily. So our mission at CMQCC is to end preventable morbidity, mortality, and racial disparities in maternity care. We create tools, including scripts and education materials, and improve outcomes through data-driven quality improvement. We all must listen with our hearts and minds, and remember that the more different someone is from us, the harder we need to listen. Thank you.
Okay, so now we have time to ask questions. So if you have question, you can write down on the cards and then we will get those answered. Also virtual, Camila, you can check if there are any questions on the virtual platform. Do you have? Okay, good. Go ahead. Okay, I got one question here. Congratulations on the big win for the advisory report. So when will California hospitals be required to change the advisory about the aspirin's birth defects? When?
Right. That's a systems question. That's really hard to answer. Unfortunately, I don't have an answer. This should have been done years ago, right? So we can only work together and, continue to collaborate and drive change.
Okay. So next question is, what are BP parameters for preeclampsia? And is there any info on taking, I think 81 milligram versus 162 milligram? One tablet versus two tablets.
Okay. So I'm not a clinician. Let me say that, okay? I am a public health person and a community person. So I do not have the answer for the parameters, but we do have Dr. Williams in the audience if she'd like to answer that question.
Okay.
She needs a mic.
Yeah.
Sorry. So in general, you diagnose preeclampsia with systolic blood pressure of 140 over 90 or diastolic blood pressure over 90, 4 hours apart. So that's how you have your blood pressure measurement plus proteinuria or any of those other features such as kidney dysfunction, liver dysfunction, et cetera. that define preeclampsia with severe features. But that is a level of detail we don't need to go into today. In terms of the 81 milligrams versus 162 milligrams, there are studies that are done on both, and there are some populations in which it has been shown that the higher dose is more effective, but the recommendation from SMFM and ACOG now is still at the 81 milligram level.
Absolutely. And I've also read that providers do things differently, right? And so some providers give 2 tablets based on weight, is what I've read in the evidence as well.
Camila, do you have anything?
Yeah, I'll share one of the questions from the virtual space. They said you are an MD. It reiterated, yes, that you're a doctor of public health. Yes. So she says, yeah, many of us are not. Is this info that we could legally be able to provide, or would it be considered prescribing? So I think the question is about kind of like the scope and that it's for health education.
Right. So, this is all, we're not making this up, right? This is ACOG and SMFM and the United States Preventive Task Force. So this is real, and they all came together and recommended low dose aspirin. So no, I would not, that's not illegal. It is out there. It is evidence-based.
Okay, I have one over here. Has this information been presented at AAP and AWHONN conferences, or is there any journals?
You know what? We just started with this campaign, but and Dr. Williams, I see her in the background. I was just gonna say, yes, Melinda Kent, my colleague, who I love dearly, she will be presenting at A1 in the next couple of months. So please look out for that. She's amazing.
Okay, I have another question. Are you considering Santa Clara Valley Health System to be a part of LDA?
Absolutely. Yes.
Okay, another one. What findings did you uncover from those who use the telehealth BP cuffs? That data can be sent to the EPIC for early intervention. So just wondering what was found.
Dr. Williams, does she have a mic?
Camila has to run again.
So there are a number of different studies that are looking at how well remote blood pressure monitoring does in terms of getting people the appropriate follow-up postpartum and also shrinking disparities. So there's one particular organization that showed complete elimination of the disparities between Black birthing people and their white peers when you actually gave them a cuff in the hospital at the time of discharge, in terms of meeting the follow-up recommendations from ACOG. So if a hospital is interested, and it doesn't have to be the remote ones, you can do an old-fashioned blood pressure cuff too, but if you're doing an old-fashioned cuff, then you need the nursing staff to be making the telephone calls, which will actually probably cost you more than doing the remote monitoring in the first place. So getting that remote blood pressure monitoring is really essential and life-saving.
Okay, thank you.
Yeah,
Thank you.
so hold on. Dr. Igbinosa.
I'm so glad we have doctors in the house.
I just wanted to take the alley from that and just say that you can get over-the-counter blood pressure cuffs and then bring it to your clinic to have it calibrated. And so that's often what we recommend people do as well. So I just wanted to say that's another way that we encourage people, like, hey, let's just make sure that it's actually accurate.
Okay, thank you,
Thank
thank
you.
you. So Camilla, do you have any question or I have one more? Yeah. Okay, so we have 2 more minutes, so yeah, we can answer one more. Is the recommendation that every pregnant African ancestry woman take LDA?
So remember that I mentioned those risk factors, right? Being Black is a risk factor, right? So they should be considered to take low dose aspirin. So my answer is yes.
Any other question?
I'll ask this one. I think it's from Ayana. Thank you, Ayana. Can anyone join the LDA Patient Advisory Committee and how?
Yes. You know, so I welcome, I mean, I think this is great. I think it's needed. I think it's really important in this type of intervention, really to hear patient voices and understand and listen to their experiences. So we can talk offline. You know, we haven't selected our hospitals for our next cohort, but we can definitely talk offline, but the more the merrier. So I welcome it. Thank you.